Hello everyone, thank you for joining our webinar. You're all very welcome today. Our topic today is the development of posture and motor control and how early intervention strategies can promote function. Your hosts today are Laura Finney and Rebekah Tinney. Laura is the Clinical Research Director here at Leckey and Rebekah is our physiotherapist. Before I pass you over to Laura and Rebekah, I just wanted to let you know that this webinar is being recorded and can be made available to you after, should you wish to see it again. You will also see a question box on your screen during the presentation, so feel free to ask any questions and they will be answered at the end. To avoid any interference, could you all please keep yourself on mute for the duration of the presentation? That would be great, thank you. And I will now pass over to Laura and Rebekah to begin.
That's great, thanks Louise. Hopefully you can see the screen and hear me, and you're all very welcome from wherever you're listening into. We have a lot to cover today, so we decided to break it into two halves, with the first half focusing on the theory and the second half giving some more practical strategies. So let's just crack on. So what we're going to cover today and the learning objectives are really in this first half to understand the maturation of the nervous system in typical development. We're going to explain how this leads to the sequential development of head and trunk control, and also be able to recognise the impact of any cultural norms or training on motor development. And lastly, we're going to look at techniques to assess head and trunk control, and most importantly, the bit that Rebekah will cover is how you translate these into strategies to maximise function. So the topic of head control. It's one like we all deal with in everyday practice, and it came up as part of clinical discussions at Leckey during new product development, particularly for our new My Way walker. We were really astonished at the combined effect of supporting the trunk and upright movement on head control for some children. And it seemed to be those two things combined that really stimulated our internal discussion amongst the team about head control. And at that point, we had to take a step back and realise that we didn't really understand that much about head control. Yes, it was always assessed, but it was quite simply with categories such as, yes, they have it, no, they don't. Oh, their head control is emerging or it's intermittent, depending on what they're doing. And yet, I think we were all guilty of going on to look for other skills, despite this very first one not being achieved. So does that sound familiar to any of yourselves? I'm sure it does. So it made us think, what could we do? And these are the sort of questions that came up. Really, what is head control? How does it develop? What's typical head control? What influences typical development? What's going to be the impact of any delay? And how can we use this knowledge on our clinical practice, especially in this world that we deal with in postural management? So we decided to go back to the books, and we did a literature review. So we wanted to look at this subject objectively and sort of take a step back and see what the literature out there was on head control. And we did quite a formal literature review and came up with 46 what we thought were relevant papers. And that just outlines the search strategy that we used. And to our surprise, there wasn't one single standalone definition of head control that we could find. So maybe that explains a lot of the confusion amongst our own clinical team. So what we did see was that some researchers were borrowing definitions from various assessment procedures. This is if they needed a relevant measure for their own particular intervention. For example, some were using sort of measures out of the GM-FM, the gross motor function measure. Yet other researchers were using developmental norms. So, can the child hold their head up during sitting? And yet other researchers were actually constructing their own definitions, which were very specific to their research. And of course, all these different ways of coming up with a definition of head control made it very difficult to compare between the research papers. However, thankfully, what we did find in the literature was there was much more emphasis on the development of head control, and that was given much greater attention. So that's what we're going to look at today, so the development and the purpose of it. So let's take a step right back to fetal development, and this is something that really astonished us when we started looking into it, that the first sidewards head movements are seen as early as 8 weeks in utero. And then by as early as 11 weeks, you can actually see the full gamut of movements of rotation and, rearward and forward flexion and extension. And the infant, continues to practice and refine these movements right up until birth. So it's obviously one of the early key movements for the child. Now, of course, we know at birth, the first movement, the baby's generally in supine, when in their arms or sort of unsupported, laid down. And due to the weight of the head, it tends to, when it's not supported, it will fall to one side. So initially, when it's relaxed, it's going to fall to that side. But there's also, from birth, from the very first day, there's the rooting reflexes present from birth. And that enables the child, when the cheek is stroked, to be able to turn to the breast to be able to feed. And very quickly, the baby learns to integrate this reflex into sort of a functional movement. So at birth, it's moving to the side from reflex or from the weight of the head. Then the central picture is what you see is the increased tonal response when the baby's distressed or crying, and everything moves then back into midline. And by about 4 to 8 weeks, the baby can then actively hold their head in midline. And then that's when we start to see these other lovely skills develop. We have the visual fixation on an object, and they're then starting to be able to eye track, and with head movement and without head movement, before finally voluntary head movements are seen at about 6 to 8 weeks. So what's happening during all this development? Well, look at the number of muscles involved in blue just for neck rotation. When you see the range of muscles and the complexity of this supposedly, simple movement of just turning the head to the right or left, rotating it, we could understand just how complex something as gaining head control can be. And I think this is really useful to remind ourselves when we see those older children and they're still having difficulty with this very first basic movement of rotation and bringing back into midline. That is the number of muscles that they're trying to control. But for a typical development, despite this, at about 2 to 3 months, the level of head control seems to change dramatically. And there's this major adaptation to the environment. So this magic sort of number at around about 3 months where everything just sort of clicks in. And what's going on? Well, at birth, the brain is just flooded with new sensory information, and the baby makes sense of this by forming new neural connections. Crucially, the more exposure, the more opportunities, the more connections. So the baby's synthesizing all this information to work out what random movements are actually useful. And then repeated patterns of this motor activity get reinforced, while unused patterns get eliminated or pruned during childhood, just to keep improving the efficiency. So very simple neural connections form first, very simple patterns of movement, and they gradually become more and more complex circuits. So this was something that amazed me. How quickly are these new connections forming? Well, in Nelson's book, From Neurons to Neighborhoods in 2000, he stated that in the first few years of life, there's more than 1 million new neural connections are formed every second, which is just phenomenal. A number so large, it's hard to process. But crucially, what we also see is that these neural connections for different functions are happening sequentially. This is really important for postural development, because look at that yellow line on the graph. We've got age along the bottom, and the yellow is the sensory pathways. And at birth, it's practically a vertical line. Those are the first ones that develop. So extremely rapidly following birth, they're exposed to so much new information in the environment. So sensory pathways that really start to get stronger and formed. Then more complex functions, such as language, build on these simpler, earlier ones. So it's reassuring for those of us maybe dealing with toddlers to remind ourselves that these higher cognitive functions, such as reasoning, they develop much later. Indeed, the frontal lobe, which is responsible for judgment and planning and assessing risks and decision making, it's the last part to develop, and that happens around age 30. Quite shocking. So it's not till 30 years the brain really has finished maturing. So although the timing of these early sort of development is genetic, very early experiences and interactions with the environment are going to determine whether the circuits are strong or if they are weak. So as I said, that 3 months of age for a typically developing child will establish considerable amount of head control. What you'll find is a substantial increase in the neck muscle strength, and this will enable that lovely controlled movement of chin tuck when they're in supine and improved alignment. And you can see the baby in the picture being able to look and focus and follow their hand movement. So that's the age where they start sort of noticing their hands or maybe their feet in front of them. So while they may not have great upper limb or hand control yet, their head and eyes will be able to track, which in turn is going to improve hand control. And this is when we see the start of the integration of the neck riding reflex, when the head turns and the whole body turns. And that's going to help with rolling and transitioning between positions. Also by 3 months, there's this dramatic sort of sensory development that's associated with transformation of neural functions. So you get an improved vision, visual attention, binocular vision, and gaze control. And gaze control is an interesting one, fascinating. It's a very dynamic and complex process where the object and the head are both maybe moving. So the eyes must be able to follow the object, the toy, so that's called pursuit, as well as counteract for any change in speed or direction of the head. So if they're being pushed along in a buggy or a pram, they're able to compensate for that movement. And that's called compensation. And both pursuit and compensation functions are controlled by the vestibular ocular reflex. So that eye movements counteract for head movements, or head movements counteract for eye movements. And it's all about keeping that vision stable. And that's really fascinating that that's happening so early. And of course, larger objects are easier to track than smaller ones, as are objects of high contrast. And something that sort of surprised me, despite sort of in nature red being the colour of danger, it's actually black against yellow that is the easiest one to see. So that's something to think about when choosing objects for those with a visual impairment. Black against yellow is the best contrast. And again, around 3 months, this is the time the baby's starting to spend more time in an upright or a semi-upright position. And for the infant to control the orientation of their head, they have to know what way's up. They have to establish that internal sense of gravity. Okay, so they need to know which way is up in order for the head to stay upright. And that control is based on integrating sources from loads of different sensory information coming in. So you've got the visual, the vestibular, and the somatosensory signals all coming in, neatly integrated to tell the baby to keep the head upright. I also thought it was really interesting to learn that it's the somatosensory system. So that's, pressure, muscle length, vibration, and movement. And that's coming from little mechanotransducers in the muscles and the joint and skin. So that all combines into the somatosensory system. And that is more important when the head is tilted or lying. So if you're a child in a chair that's tilted back or they're fully reclined, that information is more important to the brain. While the vestibular system in the ear plays a greater part in determining what way the orientation of the head when the head's upright. So the brain is automatically weighting this sensory information depending on the position of the head. So when the head's lying down, it's putting that information sort of giving it a higher priority, which makes you think, should we be giving extra support to the head so they're getting more information in, seeing as that's the time that they're sort of weighting it higher. But when the head's sort of free and upright, the vestibular system, it increases the priority of the information coming from that system. Looking a wee bit at cultural norms, because these have definitely had an impact with sort of advice for the sort of back to sleep campaign, when there was a reduction in opportunities for prone positioning. So my generation, my mum put me on my tummy into prone to sleep, but now the campaigns for the last 15, 20 years is to reduce the chance of cot death or sudden infant death syndrome. Should be on their sleep on their back. And this, coupled with car seats and travel systems, has led to concerns about the impact on the development of motor skills. So of course now we see that specific advice for tummy time it's had to be introduced. Yet when we look at more different cultures, sort of in, say, East Africa, the infants tend to sit and stand and walk earlier, while in countries where they're maybe swaddled more heavily, the control tends to happen later. And there's no right or wrong here, these are just typical developmental norms in different countries. But it does give us insight for those with a child with a disability and a delay, that it's that awake, prone positioning or play opportunities. In the research world, they seem to use the term active handling, that accelerates the development of head control. So, practice makes perfect is what we're saying. So what is the purpose of head control, and why does head control come first? I thought a really useful definition is that by Saavedra, and when she says the task for the young infant is to stabilise the head in space over this inherently unstable multi-segmented column using an array of overlapping muscles. So pretty complicated to say, never mind do. So what we do instinctively as parents is we know this is happening, so we use our hands to guide the support of the child. So, as an infant's born, they're given full support, but very quickly we learn that they're able to start to develop head control, and we keep our support sort of up at their shoulder, even with our hand sort of near the back of their neck a bit. And we gradually, through our sort of active handling, move our hands down to support the child just where they need it. And if we move the support too low, the baby will tolerate a little while, and that's challenging them. That's where they're learning. But they'll soon let us know that they're feeling a bit grumpy and tired, and you'll give them more support and give them a cuddle. And you can see that really works well with, I think, baby carriers and slings. So when we don't have our hands to do that, that's really the job they're doing. The head control is starting to develop, but they're given sort of that trunk control. And you can see as children develop more, those slings tend to be a bit lower down around their trunk. So that sort of covered the development of the very first bit of head control, and what we thought internally it would help us to develop sort of an assessment guide based on that literature review. And we put a guide together where there's sort of 5 steps for head control. So the first one is just, can the child hold their head in midline when they're in that supine position? Because of course an asymmetric position in supine may be due to weakness against gravity or abnormal tone, causing that muscle imbalance and preventing simple midline orientation. So achieving midline control requires neck muscle activity, and I think that's often forgotten about. So just that very first step gives an indication of early development and postural control. Number 2, we then observe that the child can move their head from a prone or supine position. So in supine, you're looking for that chin tuck when they're pulled up. In prone, are they able to lift their head when they're positioned in its puppy position? In 3, it's can the child hold their head and move their head from a neutral position when they are sort of held upright. So they're supported in an upright, the seat probably with a lot of shoulder supports, trunk control. And these skills develop due to a combination of they've got better strength, their integration of those reflexes. They now need to have the head orientation in space. And we're looking within that, we're looking for independent head movement while the rest of the body is still. So that they're sort of controlling the disassociation between the head and the trunk movement. Are they given a nice clean rotation of flexion, lateral rotation? The next one would be, can the child visually track? So number 4, with or without head movement. So this is this really important interplay between vision and head control, which comes up time and time again. We're looking to test if the child can move their eyes independently of their head, or move their head where the eyes are tracking an object, and then sort of reach for objects and objects in different parts of the visual field. So accurate reaching is going to be compromised if they have vision problems or upper limb function to swipe at it. So it's important to consider any asymmetry in vision or upper limb function here. And that's where you really want to be working with a sort of multidisciplinary team with an optician involved. And the very final step in this would be, can the child sustain a head lift during transitions between positions? And I think in sort of a way of thinking about this in the adult perspective, and certainly when you're driving a car and you're maybe wanting to reach, sorry, nothing I would encourage, but if you're reaching over for something which you shouldn't be doing when you're driving, you'd be trying to keep your head upright. And we do that automatically, and that's really being able to keep your head upright as you move about, and your trunk is moving about as you reach for things. The head remains upright. So that's the final step that shows sort of full head control, and it's really important, related to balance, and important for those when your trunk is moving or you're moving about. So you want to be looking how the child orientates their head relative to the rest of the body during those transitions, such as rolling, rising to sit, and rising to stand from bench sitting. So we've attached that handout onto this webinar, so you should be able to access it. So thinking about head control and what's the next step, of course, head control is really an important precedent to visual hand regard, where the child follows the movement of their hands with their eyes and able to reach out for that object, for intentional reaching and grasping, for all those oral motor skills such as swallowing, swallowing solid food, not just liquids. So head control is really important for that. And of course, communication, both verbal skills and non-verbal, even just to be able to attract somebody's attention and engage with those around them. So all these skills rely on the development of head and then trunk control. So looking at trunk control, which comes up next, until fairly recently, the trunk was seen to develop as a single segment, but Saavedra used EMG and kinetic data to confirm that trunk control develops in a sequence, starting at the shoulders and developing sequentially down to the pelvis. Also, that the relationship between the activation of muscle and movement changes from, really erratic attempts to lovely graded responses as the trunk control develops. So just thinking about that sequence in more turn, so the baby has the righting reactions at birth, and the trunk righting reaction is triggered by the stretching of the neck muscles, where there's a sort of a rotation or movement of that cervical spine. And in supine, if the head's turned to one side, of course the whole body follows, and we see that what we call a log roll. An infant starts to integrate these reflexes in supine to be able to roll themselves independently, and gradually over the next 4 to 6 months they are integrating that reflex and spending more upright, and they're developing that segmental control of their trunk. That means that rather than the body moving as one block, so if rotation or turning appears to take place about a central axis of the body, and it starts with the shoulders and then moves down segmentally, and it's separate than the pelvis. So if it starts at the head rotation, the shoulders will follow, and then the trunk, and then the pelvis in pieces, and they don't move as one, and they no longer do that log roll. So, and then that's followed by the child being able to sit with support and then achieve sort of independent, sitting. So with that in mind, let's pause for a wee second, and I just want to sort of test yourself internally. So which of these babies is sitting independently? So look at all their postures, what they're doing, which is the independent sitter. And of course, what we're going to see is the third little one with the arms outstretched, because the other ones are using their arms to support. Some quite obvious on the ground, but even by sort of clenching the arms in, supporting the body, but bringing the hands together, either on the foot or just up at the mount, that's going to increase the control over to the head and the upper trunk. So showing a full sort of independent sitting is when you complete open chain. And trunk control is so essential to be able to interact with others. So to be able to simply look up at mum or dad and get that attention, you can see the difference of not being able to use your hands because you're resting them on the floor or you're clamping them together, to being able to reach out for a toy or grab away somebody's attention if you're non-verbal. So it's such a vital first step for future skills. And trunk control is simply part of the overall postural control. I thought this was a good definition. Postural control is really about enabling a child to perform a variety of tasks in the upright posture without losing balance. They have to learn to move within and against gravity. And it plays a really significant role in motor development. So with that in mind, what about children with an impairment such as cerebral palsy? What does head and trunk control mean for them? Well, because postural control is so integral to all parts of movement, deficits in it are going to affect all areas of the ICF COI. So it's going to affect body structure, function, daily activities and participation. So that it's going to extend to all major areas in life, such as communication, feeding, drooling, respiration, upper limb function, and urinary and bowel continence. So it's really going to impact every sort of single functional thing. When we think of kids with CP, obviously tone plays a big part, and there's a variety in the severity and normal and abnormal muscle tone, and severity in the distribution, and of course the greater the impact there is with more neurological involvement. So in terms of vision, we also see that hearing, first of all, 1 in 10 children have a hearing impairment, but when it comes to vision, it's 1 in 3 children seem to have a vision impairment. And it would, some of the literature would suggest that up to half have an issue with a visual field deficit. That, as we talked about, that interplay with vision and head control, impaired vision is going to have a major effect on head stability, because the opportunities to practice the pursuit and those compensatory gaze control movements are going to be much reduced. I think it's worth pausing and reflecting on how many times we've seen a child maybe with a head tilt or a face turn, or appearing to be looking out of the upper part of one eye, and they've got upper body adjustments. So are these coming from postural deficits? Is there a problem with a hip displacement that's caused a scoliosis, or are these actually being exacerbated by a visual field deficit? So which is coming first? Maybe an interesting one. Is it the problem with the vision that's causing a head turn or an asymmetric posture, which then is causing problems lower down, or is it problems lower down that is then of course affecting the vision? And there's no right answer here, but it does make us think that we really need to understand for every child what is the best postural setup for them, and get that sort of wider understanding of how their impairment is affecting their vision or their hearing and their tone. So given all these problems, is there any way we can assess it and then take that into practice? We know that there are more specific outcome measures that have considered this, but they're constrained by considering the trunk as one unit quite often. And they also assume that if an infant's able to roll or ambulate on the floor or sit independently, then they've got enough trunk control to do other functions, which, when we know this is often not the case. And of course, we know the child needs to be fairly compliant to follow instructions, and how difficult that can be. And although they tell us how the child did, a lot of these assessments don't tell us what to do next or where to start your therapy, and that's what us as clinicians really want to know. So there's often a lack of use of them, and what we do is go back to the simplest and easiest tool, which is observation. We're back to where we started. But most importantly, we know that the trunk is now a multi-segmental unit, and that's how development occurs. Therefore, that's how we should be assessing, and that's how we should be practicing. So what we find is a really useful technique here at Leckey is to use the segmental assessment of trunk control, the SATCO, because it eliminates many of these issues. So the SATCO is a validated outcome measure which determines the topmost segment at which the control is poor or not demonstrated. Testing starts the head and works systematically downwards, and you test each segment in turn. And you can see there the picture of the spine divided into various segments. And there's really clear indications, anatomical landmarks of where the therapist or the assessor must place their hands to assess which bits. So it was developed by Dr. Penny Butler through her time at the Movement Centre. So you test each segment in turn until the child clearly cannot maintain or control it, or it's not demonstrated. And SATCO has been shown to be a really reliable and valid measure of trunk control in typically developed infants, as well as those with a neuromotor disability. And SATCO places a great emphasis on assessing and training trunk control when the child is in this neutral vertical posture. So not just upright, but this neutral posture where the joints of their head and the trunk are neither flexed nor extended, or laterally flexed or rotated. And that's the optimum position for sensory processing, and also optimum for efficient movement using all muscle groups. So it's key is this neutral vertical posture. So SATCO would assess trunk control in static, active and reactive control. For static control, they just must maintain a posture for 5 seconds. Or active control, they would be able to do a head turn or reach both hands independently. And crucially, thinking back to that posture of the infant, they must be free from support from either the tester or their own body. They mustn't be clamping their hands or clamping down on the assessor to brace themselves. And lastly, for reactive control, they must be able to maintain or quickly return to that neutral vertical posture when they are given a brisk nudge. And this static, active and reactive control, both the assessment and the training, are all just achieved through normal play. So it takes about 10 to 15 minutes to conduct a test and requires 2 testers and somebody to sort of engage the child and clown around. And we would recommend a video, and it is a bench and a sort of a harness to hold the child, and an assessment sheet, and you just work your way down. It's a very simple assessment because the control is either present or absent, and you only score what you see. You can see an example of an assessment sheet there. And you can really use the score in 2 different ways. And that's sort of starting to bring us to the end of this first section of this webinar. The first section is, of course, to ensuring that all equipment is set up to maximise the child's function. If sport's too high, then we're going to be limiting function. Equally, if the sport's too low, and they're starting to use their body or other supports to fix and give extra support. So it's optimizing the support at just above the level where they're starting to lose control. Because if they're not given that support, it's going to lead to destructive postures such as hanging on the ligaments, a kyphotic posture, or scoliotic postures in seating, or they'll simply not have their hands free to play. So it's really important to use that score to maximize function, or you could go in a different direction and prescribe a course of targeted training therapy. Now, targeted training is an evidence-based therapy to improve trunk control using a specialist standing equipment. And used alongside conventional therapy, it can yield up to 3 times greater intervention effect on gross motor function in children with moderate to severe CP. Or what we can do is look at more conventional therapy techniques to improve head and trunk control, which my colleague Rebekah is going to chat about now. But I just want to finish with, emphasising that poor postural control, it is one of the most limiting factors in CP. It restricts skills, and therefore it's going to reduce participation and well-being. And with greater understanding how it develops and how we assess it, we should have more tools in our toolbox to treat it, and therefore increase the life chances. There's a lot of references here which we can share if anybody's interested. It's quite a lot of further reading. That concludes the first part, and I'll be happy to take some questions. We'll do that at the end. What I'll just do is change now to Rebekah presenting.
Hello everybody. Let me just set up and see if it all works. It should be, yes, it's coming. Little screen. So, as I said before, my name is Rebekah. I am the physio here at Leckey. I work quite closely as part of the clinical team looking at new product development, but also able to look at the research that's coming out there in a minute and be able to kind of distribute it amongst therapists. So following on from Laura's talk, this session we're going to look at the importance of early intervention therapy and kind of the benefits that's around that. And then we'll look then at more practical techniques of how to bring these positions into your therapy sessions and then for parents to replicate at home. So
Previously, only 61 to 64% of infants were diagnosed with CP and referred for early intervention before 12 months of age. And this is because the conservative wait and see method and kind of onward referral onto early intervention services. And this is kind of still the prevailing method for two main reasons. So first, because only half of infants with CP have clearly identifiable risks in the newborn period. And also second, because not all infants who are premature or who have neonatal encephalopathy will go on to develop CP. However, early intervention in this method can mean that infants don't get the right care at that early time when they're having that most, as we've seen from Laura's slides, that early period of brain development where all those neurons are firing and developing. So we know that research has shown that children with CP, so they reach 90% of their gross motor potential by 5 years old, with most of that potential achieved in the first 2 years of life. So hence why there's quite a lot of focus at the minute on early intervention, trying to get in there early and help develop those skills. So with the diagnosis of CP, gross motor development can be predicted for children across the 5 GMFCS levels. And this is demonstrated by Hannah and colleagues in 2009. So you can see at the bottom of the graph, you've got age, and then up the side, you've got the gross motor function measure. So how they score on their gross motor skills. So if you can see right at the start, when it starts recording, there's quite a steep curve going up. So that means that, say, from years 2 to 3, there's quite a jump in gross motor development between those years. So you can see it going up and up across all levels. And then it starts to plateau kind of around between 6 to 8 years old. And then you can see as it goes along, level 1 and 2 tends to stay at that level, but your level 3s, 4s and 5s, there seems to be a slight decrease in their gross motor function. And their skills start to deteriorate from that age. So therefore, postural management and early intervention in these early years is key, while there is a lot of potential going on. So a clear message from Novak's recent review surrounding kind of the evidence that's out there about CP management and treatment is that interventions should include the practice of real life tasks and activities at a high intensity where the practice directly targets the achievement of a goal. So the mechanism of action is experience-dependent plasticity. So this recommendation seems logical, as passive movement doesn't involve that kind of child active initiation where the child is able to then work out some movement patterns for themselves and do some problem solving and developing. With a lot of trial and error as well, as typically developing children will kind of do a lot of these skills to hone down what skills are useful for later in life. And then Novak's 2017 study, so that looked at early intervention and diagnosis with children with cerebral palsy. So they found that infants with any type and topography of CP who receive early intervention, task-specific, rich therapy at home have better motor and cognitive skills at 1 year than those who receive kind of normal care. And they find that this is when a lot of intervention happens at home, the child's in a more familiar environment and is able to do that problem solving in a place that they feel comfortable. So postural management equipment, so it not only encourages improved alignment, but it minimises deformity and also promotes function, as well as facilitating peer interaction, activity and participation. So trying to incorporate all aspects of the ICF-CY. So postural management should start then in lying as soon as it's appropriate after birth, then from sitting from about 6 months, standing from about 9 to 12 months, and then mobile weight bearing from about 12 to 18 months. So now we'll look closer at what principles of treatment we can apply to enable the child to develop their best potential. So all these points below need to be considered when planning a treatment programme for a child with CP. So for example, the therapist should know the child's visual function, including the optimum range of vision for optimum distance and for social engagement and play. So this knowledge then enables the therapist to enable the child to achieve success by keeping the toys at quite a short distance. Sessions should be kept short and frequent so the child doesn't lose interest and doesn't become too tired. And then sessions should be incorporated into functional activities throughout the day. So for example, sitting practice, so whenever siblings are about, so the child can be more engaged in an upright position, or tummy time on a parent or carer's chest when they're able to have some kind of alone time. So if we look at some different positions that children with neuromotor delay can work on their skills in, and some ideas then of how to encourage that development. So of course there are lots of therapy activities that take place in these different positions, but I've just picked out a few to go through. So first off, we'll start with supine. So this is one of the most fundamental developmental positions. So when the child lies on their back, their full body weight is symmetrically supported by the surface. This makes it a very secure position to work on, and to work on those physical, cognitive, sensory, communication skills that then provide the building blocks for more complex skills further down the line. So however, this position, a child may assume an asymmetrical position due to the effects of gravity or tone, and achieving midline involves neck muscle activity and indicates an early development of postural control that we spoke about. So for supine activities, the child should be placed on their back with their head supported on a wedge to encourage that chin tuck that we spoke about. And this should inhibit any tendency of the child to thrust into abnormal extension of their neck and trunk. So you can then encourage a slightly flexed position for improved stability. So placing a roll or a towel under their knees and smaller rolls at each side to keep them stable and symmetrical. So this should benefit a child who displays a degree of trunk asymmetry that would also then affect their neck alignment. So it's good to begin with holding, encouraging the child to hold their head in midline, and this might require some gentle support to provide that positioning. So here we see little Harper. So Harper is a lovely little one. She has a visual impairment and some low tone, and this makes movement quite difficult. So in this first video, you can see me quite unsuccessfully trying to encourage her head back to midline by using a noisy toy. So as you can see how her upper limbs and lower limbs are unsupported, and that movement from full left rotation up against gravity into midline, it's too great a movement for her to be able to do. So I then changed tact, give her lots of support at her shoulders, flexed her lower limbs for stability, supported her head to be able to achieve that nice chin tuck. And by doing that, you can see she appears more engaged and ready to work on some tracking. So here's another video of working on visual tracking in supine, this time with child lying on a wedge. So this is Zoe, who has CP and is GMSCS level 5. So here we can see my colleague Sheila initially trying to promote controlled head turn towards her brother. So you can see her neck position, excitement, and just the giggles I think her brother was setting her off. Just makes the whole situation not that controlled. So then she places a folded blanket under her neck to provide some retraction. She waited for the excitement to pass, reduced the range of movement that she was asking of her, and you could see the control improved. She was able to do those slight little movements, visual tracking, and some active tracking with her head to try and look to her brother or her sister. So here we see little Harper again. So in the previous video, you saw that with no support, her upper limbs lay on the mat and she found it really difficult to lift them up against gravity. So by placing my hands behind her shoulders and protracting them forward, Harper is able to bring her hands to her mouth and start to explore them, which you can see she's clearly enjoying having to chew on them. So by bringing the child's hand and feet together whilst in supine, this mimics typical development when children start to explore their feet and start to use some of their abdominals to find where those toes are. And this is good as a child begins to learn how to use both sides of their body together. So here you can see me trying to support both Harper's feet and hands, which is quite difficult with a child with low tone. You need about 8 arms to be able to do it. In hindsight, I would have probably used a roll to protract her shoulders to help with that upper limb movement, so I could then focus on flexing her hips and knees. But you can see then her fingers start to explore her toes and her feet when she does feel them. And then you can see as her head's been turned into midline, her then attention increases to be able to feel what's going on. And those little toys that are rattly that you can attach to feet and hands are quite nice, or like a noisy hoop or something that kind of gives them a little bit of feedback, especially for children with a visual impairment. You can see she's just loving exploring what's going on. So here you see I'm trying to use proximal control to enable Harper to work on her head control from supine to sitting. And then in the second video, you can see Zoe's mum practicing this with her on a wedge to help minimise the distance that she has to control her head against gravity. So as the child starts to develop the head control, you can slowly move the support more distal until you're just holding their hands and they flex and neck themselves. An alternative activity would be to bring the child up through an oblique angle, so you're not just getting abdominals, you're getting some obliques in as well. So next then we'll look at sideline. So sideline itself is not strictly speaking a developmental position. In typical development, children tend to pass through this from sideline by themselves. However, children with developmental delay, sometimes back or tummy line present too many challenges, where children who have uneven muscle tone or strong reflexes, which interfere with their ability to use both sides of their body, this can be a really nice position to help them bring their hands to midline and work on that developmental play. So placing a child in a flex position on their side with support to maintain the position. So a strap across the pelvis might be useful to improve stability, and then placing toys within the reach of the child's hands. So encouraging swiping, reaching, exploration with two hands, like passing toys from hand to hand or banging toys together. So you can see why I'm fiddling, trying to get Harper's legs comfy. You can see that she's able to have a ball and hold on to it with both hands and being able to get it to her mouth and chew and explore it. So now we'll move on to prone or tummy lying. So prone, as we spoke about, is an essential developmental position to utilise during those waking hours with close supervision. As we said, the recommendation is for infants to sleep on their backs to prevent sudden infant death syndrome. So it's a more difficult position for the child because to see around, they have to be able to lift their head up and clear it from the surface. So babies' heads are bigger in proportion to the rest of their bodies, so to lift their heads up against gravity is really hard work. So some children also struggle with lying on their tummy due to conditions such as reflux, and precautions need to be taken to make sure they're comfortable and safe while they're doing this position. So prone may be achieved, as we spoke about, during that kind of intimate parent-child time where the child's tummy is on their parent's chest. So the parent can then slowly lower themselves back down as the child is able to gain more head control and tolerance. And this is a really nice position for children who struggle with being prone on a mat. And it's nice to be able to work on that position. So you can see Harper again with her mum. A nice time to be able to have that really nice kind of eye contact, that close to close interaction, to be able to do some nice singing or games, and then at the same time you're encouraging that weight through their forearms and working on that neck extension. So once the child starts to feel more comfortable being prone on a parent's chest, then prone positioning on a mat could be tried. So placing a small roll or wedge under the child's chest and maybe a block or a wedge at their feet to maintain that position, and then bringing the child's elbows underneath their shoulders to encourage that propping on the forearms. So meet Oshin. So Oshin is 1.5 and has periods of high tone and struggles with fully using his right arm. So as you can see in the video, he initially was using kind of abnormal extension of his elbows with little control of the movement. And then with the introduction of more flexion, you can see automatically he is more upright and is able to take some weight. And then with the introduction of flexion, the abnormal tone was more under control. But periods where he was excited or lost control, I put in a pelvic strap and placed my hand on his hips to be able to provide that counter pressure, as sometimes that can help with head control. But we found that the best way of encouraging kind of that good movement was distracting him with toys. So this can be quite a tiring activity for infants. So it's kind of always say little and often, so you're working on that nice control without working to a fatigue. So over time, as head control improves, the child may be able to maintain head control for longer and require less support of the pelvis. So once propping on forearms with neck extended is achieved, then the child should no longer need a roll beneath their chest. And then they may be able to achieve straight arms and reaching out for toys. So this is a really important position for moving on to skills such as 4-point kneeling and crawling. So finally, we'll look at the sitting position. So sitting offers a more opportunity to be upright and social. So when securely supported in a sitting posture, the child's arms and hands can be free to handle and manipulate toys. The child can be encouraged to reach and grasp and release toys, bang blocks together, and throw things, which is a favourite activity with lots. So in terms of cognitive development, sitting enables the child to be able to view the world in more vertical plane, so helping with spatial awareness and concepts of space and distance. And as I said, it's more social posture for communication. However, this position requires the child to be able to focus on controlling their head and trunk against gravity, so care needs to be taken to provide the correct support and activities while in this position. So the child may be positioned with postural support to help them maintain an upright position. So an anterior roll or strap may assist to anchor the pelvis so that the trunk can be stacked vertically above the pelvis. So if abnormal extension is a problem, then giving the child more flexion with a wedge at their back to be able to keep this under control. So once supported sitting is in upright, the child has good head control. You can encourage the child to reach for toys held out for them, moving things from hand to hand and banging and throwing. So encouraging the child's hands to be on their knees and then progress it up as the child then starts to develop that trunk control. So at first the child is sit quite flexed with kind of soles of feet touching in that kind of ring or looped sitting. And this provides a more stable base of support. The child may be able to progress to sitting with their legs straight, then which indicates better balance and enables an easier transition away from sitting. So here we can see Oshin working quite hard on maintaining upright by propping through his upper limbs, but then is tending to kind of lean and fatigue after a while. So we added in some additional support so that his hands were able to free to be able to do lots of playing and interacting. So you can see we have the strap there, and he's chilling out at the minute, so to try and encourage some protraction at those shoulders so he's able to reach for toys. So as the child progresses, encouraging them to reach for toys placed on the floor or up in the air, encouraging reaching in front and then to the sides, and then gradually moving toys further away. So control reaching to the side is important for developing the ability to transition from sitting to lying and from sitting to kneeling. It's also important to pick the right toy for the child. So as you can see, Oshin wasn't keen on the squishy caterpillar, wasn't getting much, but as soon as the ball was introduced, you can see his interest picks up immediately and he's quite keen to do some reaching for that ball. So as the child continues to progress, so you start to reduce the support that's given. But remember, when you're reducing the support, the task which you're asking the child to do should be simplified. So as you can see in the video, the strap then has been removed from around Oshin's chest, and he's working harder to be able to maintain his trunk. So instead of getting him to reach, I'm just getting him to follow the ball with his eyes and head to just work on that head control. So then the support can be reduced further to just 1 or 2 rolls, and then upper limb activities can be incorporated. So close supervision is required during this, as saving reactions will take time to become consistent. So placing soft toys and soft cushions and support around the child at first when they're sitting without support. So you can see we've got trying to introduce some kind of early constraint-induced movement therapy, as he wasn't as keen on using his right hand. So trying to take that left hand out of it and encourage him to see if he can get the rattle with his right. So those are a few basic positions for completing early intervention therapy. So there are lots of other positions and activities that can be utilised to help with promoting development. So the benefit of children with neuromotor difficulties completing these activities and working on these skills at an early age is necessary, as it helps with eating, vision, hearing, speech, washing, dressing, work and play. So basically everything.